Today we'll be discussing the rotator cuff musculature of the glenohumeral joint. The glenohumeral joint is most often injured due to its anatomical design. When we talk about the anatomical design, we notice that we have the shallowness of the glenoid fossa. Only 1/3 of the humeral head will sit inside of the glenoid fossa. The laxity of the ligamentous structures. The ligamentous structures, the middle, inferior, and superior ligaments remain lax until excessive ranges of motion occur. The lack of strength and endurance in the muscle. The rotator cuff muscle is extremely hard to isolate and is generally weak. We see a lot of anterior inferior glenohumeral subluxations. Subluxation is just a partial dislocation without any destruction to the labrum, and a dislocation, usually there is some type of damage done, most often in the labrum. Posterior dislocations are extremely rare. When we see posterior dislocations, the reason why it's extremely rare is because of all the musculature in the posterior compartment of the upper back. What we do see is instability problems or impingements, tightnesses that occur around the subdeltoid bursa, and weaknesses in the rotator cuff musculature. So one of the most important aspects that we look at is the greater tubercle. The greater tubercle here, you can see where we have the supraspinatus muscle coming in, we see the infraspinatus, and we see the teres minor all inserting onto the greater tubercle. This anatomical design, when we look at the different movements, we see that the supraspinatus muscle does abduction, we see the infra, and we see the teres minor both doing external rotation. The other landmark that we should mention is going to be the lesser tubercle. The lesser tubercle is where we see the subscapularis muscle inserting, which its job is for internal rotation. The main job of all rotator cuff muscularization is going to be for stabilization of the humeral head. Most often when we look at rotator cuff musculature, the stabilization of the humeral head is always going to be from 0 to 90 degrees. So lining up the humerus, the head of the humerus with the glenoid fossa is going to be the most important aspect when we look at any movements from 0 to 90 degrees. So for instance, when we're doing internal rotation, which tends to be the most dysfunctional, internal rotation is also aided by the pectoralis muscle, which is located on the anterior surface of the chest wall. And the subscapularis also does adduction and portions of it extension. But again, to keep stressing this, its job is to stabilize the humeral head and the glenoid fossa during any movements from 0 to 90 degrees. When we look at supraspinatus, what we see is abduction, or moving the arm away from the midline of the body. So when we're looking at the insertion, we're looking at the insertion of the greater tubercle. Again, when its main job during abduction is to stabilize the humeral head and the glenoid fossa. The infra and the infraspinatus and the teres minor, their job is to do external rotation. Again, we see the greater tubercle, the connection here. It's also aids in horizontal abduction, extension, but again, just keep stressing it, stabilization of the humeral head and the glenoid fossa. And finally, we have the teres minor. It does external rotation. It's located on the greater tubercle, on the posterior surface of the greater tubercle. It does extension, and again, its main job is to stabilize the humeral head. So when we're talking about injury rates with all of these, what we tend to see is most of the time we see injuries occurring in the posterior compartment. And because of the location of all three of these muscles inserting on the greater tubercle, usually if we have an injury to one, such as the supraspinatus, we tend to injure the infra or the teres minor. Another interesting note is that the bicep brachii runs in this intertubercular groove, and we also see damage done to the bicep tendon or bicep brachii tendon. This concludes the lecture on the rotator cuff. Thank you.